I know. Yeah, I have no idea about, other places here in Morgan Hill. I know the two places, the Gracie Baja and Prisma. I have no idea. I haven't really seen much from them either. So it's going to be a hard time for a lot of gyms. I know Rich is still doing like videos too. I think he's still doing okay. I didn't hear about your second gym. I didn't know that was, is it still, you still have the spot?
Yeah, I still have it for now. I mean,
okay.
If anything else right now, from a small business perspective, everybody's in the same boat right now. So, yeah, everybody's in an issue right now. Some people aren't able to log in right now. So.
Oh, they aren't? Okay.
I might have, because I had changed the login on this earlier.
Okay.
So I'm going to go ahead and post up a link on Facebook. Yeah, let people know what it is. I've actually, between like trying to figure out getting online classes and, the UFC gym laid everybody off. So I brought Yannette and Don back into the fold.
I didn't know that. Okay.
So.
Okay, I'll just say the disclaimer now that we're on YouTube that I'm a Kaiser employee, but anything I say here really doesn't represent Kaiser, and medical advice or whatever it's not supposed to be personal medical advice. I can talk about some issues, but don't use it as for treatment or anything like that.
Sure.
Yada yada.
And like at least the initial batch of questions I had, like I was careful to kind of word it in your experience and what you're seeing, as opposed to, I would never have it that, okay, like, the decision to shut down the gym was all on you or anything like that.
Oh yeah,
or anything else. It's like, there's personal, like, like for liability, ethical, all those types of reasons. You're
right. I mean, I still kind of represent Kaiser because I'm a physician. So anything I say, they're trying not to have us be too political or take any viewpoints or sides. I mean, if I do give you my viewpoints, it's usually my own and not really speaking for Kaiser.
Okay. You're obviously free to say whatever you want. Like,
I think in this platform, I'm going to be okay. I don't think it's going to be a problem. So,
but like, I've kept it as neutral as possible. It's like, what do you see there? Like,
Sure.
On the front lines, you've seen like patients that have, I'm assuming you've seen patients that came in with
yeah, pretty early too. Let's see, are we gonna wait for other participants or anybody else coming on?
Yeah, Bobby just sent me a text that he wasn't able to get on.
Okay.
And I think like I said, I had changed the link this week, and I think a lot of people are looking at their old emails. But
the old ones, okay. Yeah, I just used the one that you texted me, and it worked even without a password. So
I just found out with Zoom that if you send the link, you don't need a password.
Yeah. I did it both ways. Let's see. Okay.
I'm just hoping nobody jumps in wagging dick pics or anything like that. I haven't been Zoom bombed yet.
I think it's pretty rare.
A little bit disappointed, actually.
Yeah, I wish I had a background. My Mac can't handle it for the processing power, so I just have my normal background here.
Long story. I actually have 2 laptops here. Okay, so some people are on the YouTube stream watching this right now.
Okay.
Letting us know. I'm getting texts and stuff like that. Let me just make sure that everybody has the text. Well, actually, let me, again, I'm going to give this over to you. So.
Okay.
So you can go ahead and answer questions or share your screen and all that type of stuff.
I'll go over what you went over. So the first question, what was working in the ER like before COVID-19? So I think some of you know that I work only nights, so I'm what's called a nocturnist. And my usual shift is like 8 p.m. to 6 a.m. So usually when I work, it's pretty busy. That's the busiest time. Oh, I see Paul. And hey, Bobby, what's up? Hey, everyone. How's it going?
Well, people are looking
People are logging in
on this right now.
So, hey, I should get my drink.
But why is, just out of curiosity, why is that late night shift the busy one?
I think in general across like most emergency departments, most of the traffic comes in after people get off of work. So it starts to ramp up after 5 o'clock, and usually 8 p.m. to 10, it's usually busy. And I think that's reflective of every department that that I've seen.
And usually what type of emergencies are coming in at that time of night? Like heart attacks, car accidents, gunshot victims, boo-boos.
My department is not a trauma center, so I don't get any of that stuff. If I do, and I usually do get it, we get stab wounds, we get gunshots. They're either totally fine or they're just not going to do very well because we don't have a surgeon or a trauma surgeon who's on. So most of the level 2 or level 1 trauma centers have to have a trauma surgeon in the hospital that can take them to the operating room within an hour. And that's not the case with us. So that doesn't stop like people from dropping people off like at our ambulance bay and just taking off. That's the usual thing. And they don't have a story. Usually if it's ambulance traffic, they're going to self-sort to some other trauma center, either Valley or another hospital to take care of them. So I'll see generally everything. Most people with chest pain, belly pain. We do see heart attacks. We see a lot of people, like old people come in who are sick, young people who are sick, usually with fevers and things like that. And there's a smattering of things coming in. I mean, I have like stories of all the crap that I see. And one of the most entertaining is like rectal foreign bodies, where you see them people stick up their butt and then who come out, which is just ridiculous. But that's what we get. We get people with mental health issues, which a lot of our brown belts actually know because they work at those centers. So you can name it. I pretty much deal with them when they come in, but the brunt of the people start coming in after 5. And I'll see them pretty much all night long until like 4 o'clock in the morning, it starts to tail off. That's typically my my night, and I'll see around like 20 patients, about 2 per hour. So it's in my 10-hour shift is going to be about that much. So it's a lot of patients. It's more than the day shift, but it's fine. I like to run. I like to have things going so that the shift seems a lot shorter because you're busy. And typically before I go to work, if it's 8 p.m., I'll usually go to class, and you see me in the night classes. I'll try to go every night, and that usually does help me. Believe me, if there were Saturday and Sunday classes, I'd go. And I'm one of the few people who goes on Friday night to Constantine's class, usually. Hey, guys. If anybody wants to ask a question, hey.
Andrew.
Hey. What's up, Andrew? I haven't seen you in a while.
Hey, how you guys doing?
I'm doing good. Like everybody's got their, hey, what's up?
Hey, Andrew, now's the perfect time to come back because everybody's going to be fucking, everybody's going to be out of shape. So
everybody's going to be bigger.
For yourself.
Yeah.
A different weight class.
Yep. I can't wait. I'm just better. Yeah.
Okay. So let's see. So yeah, typically I'm overnight. I'll see the stuff, the bizarre stuff comes in overnight, and that's usually my job. So it's usually pretty busy.
We actually met before he started training jiu-jitsu because I was taking my father-in-law on about a weekly basis to your place.
Yeah, I remember.
Down, like, obviously had one serious thing there, which is the one that ended it. But yeah, we got to know each other pretty well after a while.
That was pretty funny because I remembered you, and then like I asked. This is, I don't know, 2000. Like 5 years ago.
Not 5, 6 years at this point.
When I first wanted to go into jiu-jitsu, I asked one of my nurse friends who was actually a
black belt, Doug.
Yeah, it's Doug Livingston, who was over at,
moved to Georgia, right?
yeah, he's in Georgia now. Well, he can roll. Georgia's open. I think he's
true.
fishing. I don't think he's rolling. He's smart. I asked him about places to train. He said Heroes, and the rest is history after that. So, off a recommendation, somebody you knew, I came to Heroes. So, interesting story. So, so the question is, what has happened since COVID-19? Well, our hospital, San Jose, was one of the hardest hit hospitals. In fact, we were the hardest hit hospital in the very beginning. And this was in February. So the end of February, beginning of March was ridiculous because our hospital is the hub or the main hospital for the TSA workers. And we had several TSA workers come in. And I think the end of February, beginning of March, we had 15 people who were admitted. And a smattering of people, like even the janitor came in. And that's kind of ridiculous because the janitor was like, have no contact with people and he just went and cleaned the bathroom. And yeah, it was crazy. So within a few days, we were getting people coming in. So the fear was we had no idea how many people were out there and what was coming through the front door. So the biggest problem now you're seeing with most emergency departments is that everybody who comes in the emergency department until proven otherwise is COVID positive. You just can't trust the stories sometimes because some people will come in deliberately not tell you what's going on and they're coughing in your face the second you meet them. So when I go see a patient, I put on protective gear all the time. I'll put the mask on, I'll have the face shield on, I'll have the apron on, gloves and everything. And if you go in there, even without an N95, you have a surgical mask, you're pretty protected. And most of the time when we have any procedures like we put a tube in somebody's throat, that's when you actually need an N95 because it becomes aerosolized there. But when people come in, I think the saddest thing that's happening now is that people come through the ambulance, you can't treat the same. And I think you guys know about that one doctor who killed herself. And she was so frustrated with her care because she couldn't do anything for people. So this is the big flip that we have now is that I have to take care of patients. And usually I'm like, okay, I'm going to do whatever I can, even if it's going to risk my safety is actually a concern. I'll usually put the patient before my concerns. And this is totally flipped because if somebody comes in to the ambulance bay who's being bagged, which means you put a bag on their face and you resuscitate them, you have to take that off them to get them into the room. Because if you continue to bag a patient or do CPR, you'll aerosolize it and everybody's going to get infected. So we stop CPR and people, yeah, it's ridiculous. And they come in and they die in the hall and you bring them into the room and then you resuscitate afterwards. And there was 2 cases I had where people just plummeted when they first came in. And I wish I could have done something for these people. One guy came in and he was clenching his teeth. I couldn't put a tube in because now it's totally different. You can't bag them. It's not safe. You usually have a setup and you do it very rapidly. You do it with a video scope. And this guy came in and had no line. I couldn't put a tube in. He was clenched. He was pretty much dying. So I had to wait until he was more dead to open up his jaw and put a tube in. So that, I think after that night, I had like PTSD. And that was beginning of March, I believe. And so if somebody comes in by ambulance, you're really sweating bullets and you really are hoping that they're going to be okay. But if they come in under duress and they're really sick, there's not much you can do for them when they first come in because you have to assume that they're all COVID-19 positive. So that's the thing. So that's how it's changed. And now, if you ask me right now, how's the department, people are going to think it's crazy. It's not, it's dead. Nobody's coming in. And if you look across most emergency departments, there's not many patients coming to the ER. We're down to like half the census. And what we get in, I think people are just too scared to come in. And I get to see people with advanced stuff, like waiting too long to come in. That's the sad thing. Although there's been a change in the kind of patients we see. We don't see any asthmas anymore. And because the air quality is so good that nobody's having any wheezing or anything like that. And they're usually pretty well controlled. So I don't see a lot of that. We do see heart attacks. We do see strokes come in, but sometimes they come in too late, like 2 days later because they're just too afraid to come, which makes no sense because they can come to the hospital. They're safe. They can come. And I don't want them to stay at home. But I think because of all of this what's been going on, people are just too afraid. So that's the thing that's kind of sad because people's fear has gone up. Do you guys want me to talk about what the state of COVID-19 is and symptoms and stuff? Do you have any questions on that?
Yeah, I mean, like, I think there's one of the things is there's a lot of misinformation about COVID-19, or it's like if you follow along the news, like there seems like there's all kinds of new symptoms on it. It's like, oh, your feet are swelling up or something.
Let me
looks
just
like
tell
athletes
you
are ringworm to me, but I mean, maybe you can talk about, first of all, we'll break it up into, there's 2 questions I had about that. Number one, in your observations, again, I'm being careful to like, you know, in your observations, what are like the COVID-19 symptoms? And then the second part of it is like when somebody comes into you, what is the typical patient, or what's the patient marker? Like old, young, does it make any discrimination on that? Or have you seen anything like that? Okay. But 2-part question.
Yeah, there's tons of people come in, and usually what I'm looking for is like the usual symptoms are, the number one is fever. If you've had a fever, the cough and shortness of breath are the other thing as well. And it can range. And now we have like, if you've heard about pernio is these blisters that can happen to your fingers in younger people, and it can happen in other age groups as well. That's another thing. One of the huge ones is what's called anosmia. If you lose your sense of smell, it's almost 98% of people who have COVID, they lose their sense of smell and they can't tell you. So I've thought about bringing coffee beans and having it smell it and see if they can smell it.
That's a good idea.
Yeah, so that's the thing. Usually if they have those symptoms, and those people could have COVID. But I'll tell you, it's like the majority of people who do come in, if they have it, you're sending most of these people home because they're okay. And I'll tell you right now, day by day, this is changing. So this is the thing. I don't want to scare anybody, but the disease or the virus itself is just bizarre. It is unlike anything we've seen. So most emergency doctors, like, we see everything. We're used to seeing flu. We're used to seeing pneumonias and heart attacks and stuff like that. When SARS-CoV-2 came, which is the virus, COVID-19 is the disease. If we see people with COVID-19, it's taking all of us for a loop, because they're coming in with symptoms that we just did not estimate or even think of. So most of the people come in, if you're older, like 60 plus, you're not going to do very well with the disease. The reason why this is different from flu is because you can get sick from this, and it's about, I would say 15 to 20% of people are going to have some severe symptoms, meaning they'll have shortness of breath. About 5% of the people who have COVID, 5%, like 1 out of 20 will have like severe symptoms enough to be hospitalized and go to the ICU. So it's a big deal, because if you come into the hospital and you need to be in the hospital, you're going to be there for an average of 15 days. You're that sick, and you're going to have a prolonged like admission, because you're going to need oxygen and to be observed. Now what we're seeing is people, like young people, coming in with heart attacks and strokes. Now this is the thing that threw all of us for a loop. When you get this virus, it makes you what's called hypercoagulable. So you can make clots, even young people. And there are people coming in with pulmonary emboli, which are these clots that go to your lung, and you can have heart attacks and you can have strokes. And so they're clotting like crazy. And now we're looking at people, we take an index to see if their clotting factors are hyped up. And if they are, they get on an injectable medication called enoxaparin, which will thin your blood. And I think that's what we're going to do for anybody who comes in. So the treatment is now changing by the day. So just as a couple days ago, we're being asked to draw titers on people for what's called a D-dimer to see if you or clotting factors are out of whack, and then possibly start you on a blood thinner. Aspirin is not one of the medications that we tell people to use, because it'll make you more susceptible for getting severe disease in it. But now I'm just kind of wondering if they're going to talk about starting people on aspirin afterwards, and how much data is behind that. So we don't have much data. We're getting bizarre symptoms coming in. We have like these grand rounds, and we have these meetings about what to do with patients, and it still continue to change. So the scary thing is, although we're trying to think about taking people off shelter in place, we don't even know that much about the disease. So
yeah, that's my perception. It's like there's something new every day. So I feel for the people who want to go back to work and like Gumby and gyms and
yeah,
but man, it seems like we really don't know everything we might need to know.
So
yeah.
Here's the thing, like if you really want to look at a good like discussion about the disease and how it's going to and economic impact and about bringing people back to work, look at Stanford's Grand Rounds, because I just like watched it yesterday. They have people who are like, there's economic professors, there's lawyers there, and you also have your infectious disease doctors, and they're looking at this, and it's kind of a weighing thing of like trying to reduce the amount of disease that's out there versus like the economic hardships. So because we started shelter in place, this is one thing people should know. We've reduced the amount of deaths in this country by like, I think 1,600 people we've saved. For every one person that we save, the life that we save, we've lost 400 jobs. That's a ton. So if you want to see a fast track to even more poor health, make people poor. Right. Poverty is one of the worst things. So they are looking at this, and they're unfortunately going to have to put a dollar amount to these lives. And I know it's terrible, but that's what economics does. It's not trying to be cold. It's just trying to put a target on things. And eventually we'll have to leave shelter in place. Now, ideally, and this is the thing I'm going to tell everybody, everybody's going to get this disease. Everybody's going to get COVID-19 sometime in the next 2 years. There's just no way you can avoid it, because you can't really eradicate this disease when there's, in this country especially, because people just, their rights are like paramount. You can't do this to me. I want to leave shelter in place. And there's going to be some Yahoo who's going to break it and go out there with a cold and infect other people. So you can't really stop people unless you have like a really hard line. So I posted before on New Zealand, and New Zealand had very, very austere measures to control the disease. So you have a country like that, which is pretty much eradicated it, because they had like, I think 1 death, and their cases have gone down to like 0 in the last few days. So have they under control? Yes, they do. But guess what? Their entire country is naive to coronavirus, meaning they can be susceptible again. So it's a thing. If you actually change this or flatten the curve, yay, everybody is getting better. And just to let you know, we're at the end of the beginning. That's it. Now we're in the middle part. The surge that I was worrying about, like the surge of patients, has not happened, and we don't think it's going to happen now. In Santa Clara, it's not many cases, 150 right now. And I think this the hospitalized people. Our surge bed capacity is at like 90%. ICU capacity is like 15 or 12%, and we have like 1,000 vents, and we've only used like 100 or so of them. So we have enough vents to take care of people, and we have enough sick beds to take care of the really sick people, and we have enough surge beds to take care of the surge if it'll happen. So is it going to happen? Yes, it'll happen probably later on, probably November or something like that. So we're always looking for the influx of patients. So as we leave shelter in place, this is the thing to remember, we're not going to see the surge in the people until like a month later. So everything is delayed by like a month. So if you saw in the last 40 days, we're okay, it's because we instigated those measures back then. So like I said, you're dealing with a disease where there isn't, we're naive. We've never seen anything like this. Like flu, we see in the 1918 Spanish flu, nobody had this flu before. Afterwards, the herd immunity went up, and most of the time, if you get a flu, it's not going to be quite as bad because you've had your immune system's seen something that's close to it. Coronavirus, hell no, we have no idea. So like I was saying, in New Zealand, they've eradicated it, yeah, but they're susceptible, meaning their entire immune systems in that entire country doesn't know what this virus looks like. If you take Italy now, and everybody thinks that Italy's hosed, well, guess what? Their herd immunity is going to be way better than ours because they've been exposed to it. And I'll tell you, the number of people who've had in that country who've had it is going to continue to go up, and they're going to be in a better place later on and actually rebound at some point faster than we will. So when you end shelter in place, ideally what you want to do is do it in small like increments. So the ICU beds and the hospitals will not get overwhelmed. But the sad thing is you're going to have people who are going to die. So if I was the president and I want to do this, yeah, you want to end shelter in place at some point, but you have to have some plan of action. So do you make people who have had it before or have been immunized to it? Do you have like these immunity passports? This is something the World Health Organization says don't do, but Germany's going to do it. And I bet you we'll start doing it too. So if you have like antibodies to it and you're quote unquote immune, then you can hang out and go roll again, which I would love to do. But I'll tell you, there's no data on that yet. But given the way the
United on the antibodies, since you brought that up, and one, there's been a couple of like conflicting stories. Like there was the Stanford story that, you know, maybe like in Santa Clara Valley, like we only had like 1/10 the amount of people, like, or like it was some like astronomical number on that, the people that had it. And there was another study or something that's like the first person actually died well before we thought had it. So there was that. So, I mean, do you hold much stock in the possibility that this was out and about before the shelter? I mean, it's obviously out before the shelter.
January.
Hold stock that it was bigger before that point, or does that change anything about when we move forward on this?
The Stanford data is interesting, but they only, honestly, they try to test a lot of people who came in, and it shows, their data shows it's a lot more widespread, which I'd really like to see. I mean, I'd love for this to be less deadly. If there's a lot of cases that are unreported, not coming to the hospital, because only what we have in our database is stuff that people who present, if they're sick or anything like that. And the testing has gone up and we're tracking more things. And I think the overall mortality will go down because we'll find out that more people have had it. The interesting thing is that there are people who are positive, and this is a question, were people like lapsing with their immunity if they tested negative afterwards? And it turns out that people can still have this COVID-19 for a longer period than we thought, up to like 40 days. And I made another post about that too, about having quarantines extended to like 40 days, but they're very, very rare. And so we used to think that people were shedding viruses who were asymptomatic or not having symptoms, and that turns out to be very low as well. So I think after we get more antibody tests, I think we'll see that it's the preponderance of sick people is less than we think it is right now. It's not as dire, maybe to half. And I also want to caution people because the antibody tests out there, the ones that are coming from overseas, they generally suck. They're not very good. So don't really waste your money. If it's the Abbott test, yeah. Stanford's test is pretty good, but still it's not perfect. And they're still looking at titers to see, you know, what's real, what's not. So as we get more data back, we'll get better ideas. The question though is that people, if they have the antibodies, are they protected from reinfection? And we think you are, but then there's these cases that come back which just completely blow our minds. Like there's a patient recently who was discharged who had negative COVID, come back and get it back again and die in the hospital. So like I said, I'm not trying to— Is it
your hospital this happened, or is this a study you read?
Oh no, it's happened in our hospital, isn't it? It's absolutely ridiculous. And these are other people as well from other hospitals. We have people who were sick, who got better, tested negative twice, went home, came back, died.
Dr. Mike, I read an article on that phenomena, and the article hinted that maybe it was because the test was actually wrong. In other words, they weren't negative. They never were negative, and they had it.
So here's the thing, when I first started this in like February or March and stuff like that, we only had 50 tests in Santa Clara. That's it. So you couldn't test anybody. And now we have new tests. We were sending it to Stanford, and then we had a local test. Now we have the local test, and we have the Abbott test, which can come back in like 8 minutes or 10 minutes. There's several tests that we have. And in the beginning, no, it wasn't very sensitive or specific. Now it's better. And yes, it may have been that that person actually was still positive and may have tested negative. So there's a lot of balls in the air right now.
And I think that same article was talking about the 40-day span. So, you know, you test negative, but the test is wrong and it's actually 40 days. So now you have a situation where you think you're okay, but you're not.
Yeah, exactly. Yeah. So I think that's it's going to generally come down to, that we will have to get some more robust testing. So when we end this shelter in place, there has to be some plan of action. And I think Congress was actually told, if you're going to do tracing and testing, it's going to cost like, I think on the order of like $47 billion to do this. Because that's the way you're going to have to do it. You're going to have to, when you end shelter in place, track the disease. Testing has to be much more widespread than it is right now. It's getting there, and by August probably we'll be where we need to. I can't tell people what to do at this point. You just basically shelter in place until the governor tells you to. I would also be very careful about contact with people, even if that's lifted too. I would like to see a vaccine out there so we can get people the herd immunity up, so that we're not going to get into trouble. And I'll just tell you right now, people are thinking about getting infected with this stuff. Don't, because it's terrible. It's like 1 in 5, you're going to get real sick. 5% chance of dying across the board, and then bizarre stuff happening as well. So you really don't want this. I don't want it. I don't want to see anybody else with it. If you're a kid, it's a different story. Most kids do fine. And I'm talking about people who are under 18 years old. The virus binds to a receptor that's not really present in kids, in the lungs. So those kids will never get the respiratory problem that usually adults have. If you're above 60, avoid it like the plague, stay indoors, wait until a vaccine or something, until we get a better hold of the disease and we get some better data as well. So everything's going to be up in the air. And like I said, imagine this like a piece of bread with mold on it, and eventually that mold is going to get to the entire piece of bread. Everybody in the United States is going to get this. That's what this curve is going to be. And the reason why we're trying to flatten it is because we don't want to overwhelm the ICUs and the hospitals, but eventually we will get it. So the two models that people are thinking, like, oh, why don't we just get everybody infected and we'll develop herd immunity? Yeah, that'll happen. And then you'll have no fear because everybody's had it. But then you're going to get a crap ton of dead people. And that's unacceptable from any way you look at it. But this is what people are saying in Facebook, and it's really concerning. So end of May, June, that's going to be kind of an interesting thing. I'm not quite sure what they're going to do at that time. I really hope we get some advances so we can end shelter in place and have a better idea. Unfortunately, I don't see jiu-jitsu being part of that, which sucks, because it's the highest risk sport of all when it comes to transmitting COVID, and that sucks. Let's see. Can we get another question?
Let me look at the list.
Yeah. What can you do to prevent the spread of COVID-19? This is a virus which is spread by droplets. And what everybody tells me, I think the fear is people say about aerosolized stuff and those tiny little particles. Well, I'll tell you the thing is about aerosolized particles, they don't stick to anything. So if you have an aerosolized particle, it's just going to pass in the wind. It won't go anywhere. It's just basically like a little piece of dust, and it doesn't stick. So the only reason why we use N95s is because when you're breathing hard right next to a patient who's actually getting intubated or has a nebulizer going on, you can, if you're close enough, get some of those, because you're going to overload the number of particles you're going to have. Is just going to be ridiculous. And that's where an N95 actually does help you. So most of the particle sizes that you need to stop will be stopped with a surgical mask. And most of the masks that people are getting are pretty darn good. So it can only go to your mucous membranes, meaning your eyes, your nose, and your mouth. So if you cover this area and you get showered with this, you don't get infected. It won't go anywhere if you are very careful about that and not touch your face. And I'll tell you, it's really hard not to do that if you touch any part of your body which has it, and you touch your eyes or your mouth, then you'll get it. You'll transfer it to your mucous membranes, and that's how the virus actually comes into your system. It doesn't go through your skin or any other place. As ridiculous as it sounds, really just washing your hands. Don't try to touch your face. The mask is there to protect other people, but also because it keeps you from touching your face. If it's really on, if you have glasses on or something like that, you won't be able to touch the areas and cross-infect yourself. And just be careful with touching your face. That's the biggest thing. I think you also asked about how to support frontline healthcare workers. Just tell them you're doing a good job. Just say thank you. And I think that's all we need right now. I don't really need anything. I don't need free meals. I don't need I actually have enough masks and everything that I need right now. And the hospital is procuring more protective PPE. And hopefully, we'll have, by the time I get back to work, I don't think it's going to be that much of a problem. Just, say hello and ask us how we're doing. I think that's the biggest thing. So, anything else? Anybody have any questions on this? I know this is all confusing and nobody's really giving you a great concise answer.
I'll throw out one more question, and then hopefully other people have questions too. So I mean, from what you're saying, it doesn't really matter a makeup or or obviously kids can't get it, but seems like everybody can get it. Mm-hmm. Is there a commonality that if somebody came in with symptoms, they can say I visited this place or I engaged in this activity, or is there something that people have done that put them more at risk at this point from your observations?
Well, it's contact. It really is. If you talk to somebody and you're within 3 feet, the droplets will go to you. So just the act of talking will spread droplets, and you don't see it, but it's microscopic. It happens, and tiny little particles will go off, touch you, your face, and can get into your mucous membranes. And it's something that you can't really sense because they're so small. So anytime you're within 3 feet, 6, I think it's safe. The difference between 3 and 6 in my book isn't too much. I think 6 is kind of a little bit overkill, but that's it's hard. If you have a bubble around you between 3 and 6 feet, I think you're okay. Usually people, if they do have contact with somebody, the mean time of showing symptoms is 5 days. It can be up to 10 to 11 days, but most people see symptoms in about 5 days, and that would be fever, the number one thing. If you have shortness of breath and stuff like that, that's also another thing. The weird thing is there's people coming in with diarrhea. And you can spread it because COVID goes through the diarrhea too, so it seems gross, but especially when we're hearing about people crapping on the streets, you can get it that way too.
Not to be funny, I've heard something can farts transmit coronavirus?
I don't think so. Okay. No, I know. Yeah, it's gross to think about. It has to be a real kind of droplet. If most people have their pants on, it's not going to go. It's not going to go up to you. You'll smell it, but that's about it.
So only sharks.
No, you have your pants on.
Oh,
yeah, exactly. So if you have contact with somebody, you should show symptoms in about 5 days. If people get it and you have any kind of symptoms of fever or something like that, you talk to your health professional. You call up the advice and you ask them what to do after that. If you're having shortness of breath, that's a bigger deal. And I think you should probably be seen if that's the case. If you don't, you just have a fever and you're doing great, fine. But be real honest with yourself with your symptoms, and don't not come to the hospital because you think you're going to be inconveniencing people. Just go and see them because your health is our number one concern. So the definition of an emergency in this country is not what I think is an emergency, is what you think is an emergency. So if you think it's an emergent condition, it is, and then you come in. Because if you downplay your symptoms, if you think you're bothering us, that's where you get in trouble. Those normal people will start to stay at home, and then that's also a bad idea. You're not inundating us now because actually the volumes are down. So if you have a question, if you want to see somebody, that's fine. Come in, go see us. Want to message me? Go ahead. I don't care. I'll give you kind of like direction if you need to. But I'll tell you right now, since we've done shelter in place, we've done pretty good. We've avoided a lot of the surge and everything that was worrisome, but we're still susceptible. We're still naive to this virus, and we're all going to get it at some point or some form of it within 1, 2, or 3 years, because it's going to continue to come back, back, and back. I know it's depressing to hear, but this is my life from now on is going to be putting on PPE for anybody who has a fever until I'm vaccinated and we know that I'm protected against the virus at some point, and we'll get some.
So, Dr. Mike, if you think within 1 to 3 years everybody will be exposed and get it, which is what you're saying, do you then foresee a huge mortality rate in, for example, people older than 60 or 70 or 80?
Yes.
That is sad.
It is sad, and that's a thing. And already, 65,000 people out of the million that we've seen. This like far eclipses what H1N1 or swine flu did in 2009. 2009 compared to this, 2009 was like a walk in the park. And I thought that was bad because there was a lot of people coming in, a lot of hospitalizations. I think it was only like 15,000 people who died in the United States. That's it. Out of the 60 million who got it. So you have like 0.00008% chance of dying if you got the flu. So people were comparing it to the flu, saying it's not worse than the flu. The flu is worse. That's complete and utter bullshit. It's way worse than the flu, and actually the mortality rate is way higher as well. And just watch that thing go up, and it will continue to go up because we haven't even flattened the curve in the United States. So if you ever look, at world meters, I know you see like us at the very top, but click on the number of deaths per like millions of people, and you'll see that we're actually not that bad. But California, if you look at the deaths per like millions of people, we're actually doing excellent. The ones that are not doing so well, New York, we already know is a complete catastrophe. And the numbers they have, like 1,000 per million people who have died. Ours, I think, are like 51. If you look at other states, they're doing terrible. And these are states that are saying that they're okay. And I worry about those states because if they start to explode, they're going to be like New York too. So that's the thing. I don't know how well shelter in place is going up for those places, but there's plenty of places that are going to mess up. But the frustrating thing is there is no national standard for this. There's no question about shelter in place or any guidance. And that's the thing that sucks because our borders are like non-existent. People can come into this state as well and kind of mess things up. So shelter in place only works in the place in the area that has it if you can control the borders like New Zealand did. Any other questions? Did I answer your question? Yeah.
Hey, Dr. Mike, I don't know if anyone's asked this question, but how far off is a vaccine, or I guess how far out?
Oh, okay. So they're testing one now, and you got to remember that this vaccine is not like flu vaccine because it's totally different. So flu vaccine has been studied. We can crank out a flu vaccine within months, you put it in eggs, and you can get your vaccine within a short amount of time because it's been studied and we know about the risks and benefits from it. So now I think they're going to rapidly clear this vaccine, but the thing that I'm worried about is there's going to be no real QA measures for this virus, and you're going to start experimenting on people. And if you remember, like 1968 when swine flu first came out, a lot of people got what's called Guillain-Barré, which like 50 people died nationwide, where they were paralyzed and died from that. So that's the thing that kind of worries me. The other thing, I just don't know what's going to happen if you're immunized, if it's going to make things worse for you as well. So the thing about COVID-19 is what's called cytokine storm. So you have your regular like cold-like symptoms from it, but a select few people will just like, their immune system will light up more inappropriately than anything else, and they'll develop clots. They'll start attacking themselves, get pneumonia, which kind of fills up their lungs. The thing I don't know about this vaccine is it going to make that worse? That I don't know. But what we have seen is people who actually donate plasma to people, those antibodies come in and really help people out. And so the severe symptoms kind of go away as well. So I think if the vaccine comes out, you're going to be in a way better place. And I think you're not going to get as sick as other people when you do get it. I just don't, there's like no data yet. And so they've developed it. I think there's several ones out there. And so soon, if it does come out, heck, I'm going to volunteer. I don't care. I think it's probably best to get people immunized. But I don't think it's going to happen in the next 6 months. I really don't. I don't think this is going to happen very quickly because they have to do some trials. They're going to have to do a short amount of people to see if it works and then see if there's any like negative outcomes. I know we're going to try to push it out, and I know it's going to be pushed out faster than it's supposed to. 6 months is a good, comfortable measure. It's probably going to come even sooner, and it's probably going to be a little dirty when it comes out. Do I think it's necessary? Yes, but I would not see this. I wouldn't count on this vaccine coming out for at least the next 4 months. That's my guess. Any other questions?
Yeah, so you already mentioned it. So do you have any data on how it affects people with autoimmune diseases, immune diseases? So any tests being done so far? Or?
Autoimmune diseases are kind of an interesting thing. And then the sad thing is that there's people who are on chloroquine, hydroxychloroquine, Plaquenil, all those things, which we're treating people with. And honestly, I don't think they really work. I think it causes more problems than anything else. We're seeing people who have like, people will do worse with this virus if they have more inflammation. And that's a key. So if you have an inflammatory like status, you're more prone to get this, what's called cytokine storm, and have a kind of a reaction which is above and beyond what you actually need to. And that's where people get sick. So people with underlying low levels of inflammation, and that includes people with autoimmune diseases, I think will tend to do worse. Now, people with low immunity, we used to think those people would get hosed by this virus, but it turns out if you have an immune problem and you have a lack of immune system, you actually are more protected. And there's people who with crappy immune systems who just like the bullet time and Matrix, just dodge everything. And it's just bizarre because you think these people would be susceptible to it. But the problem with the disease is the inappropriate immune response to it. So if you start to clobber it and cause more inflammation, you end up even worse. So they've thought about using steroids and things to bring down the immune system, but it hasn't worked very well. So that's the thing, to answer your question, you're more susceptible to the bad outcomes if you have an autoimmune disease that I know of.
Okay, thank you.
Mm-hmm. Any other questions?
I heard you say that it doesn't affect kids. What about sorry, my wife's does that apply to kids under 1, like babies?
So,
as you can hear mine in the
majority
background.
of kids who do, I mean, really, really young kids. There's been a couple like accounts, but it's so rare. It's so rare. So it's not in the if you're thinking about COVID-19 and causing like people going to the ICU and having low oxygen and stuff like that, that we don't really see in kids. You don't, because they don't have the receptors for it. So the virus comes in and it binds to a receptor called ACE2, which adults have, and kids don't. They just haven't developed that receptor. So it can't invade the cell because it's just not there. You will have an immune response to it. You'll get a cold. It'll hang out looking for a fight and looking for a place to enter and cause damage, but then it really won't go anywhere. So it'll probably go into the kid, not bind to the receptors that cause the problems in the lungs or other places, and just kind of look for a way out. So kids, any kind of kids who, especially if you're breastfed, usually they'll get antibodies from mom, usually IgA. and they're more protected, and they lack the target cells that will really make you sick. So most kids who come in, they're a vector, they can transfer to other people, they definitely can, but really sick, no, they usually don't. They're usually pretty protected, even kids under 1, because those kids usually will just get a cold and they'll be okay. So it's the adults who have that receptor that, where you can get in trouble, or you get this, what's called cytokine storm. And that only happens, from best of my knowledge, I think with adults.
Cool, thank you.
Mm-hmm. Any questions? Any other ones?
Yeah. Hey. So I'm not sure. Maybe you talked about this before I got on the call, but
yeah.
What do you think it's going to look like for us specifically in our sport when they do start lifting the shelter in place?
It's going to be terrible. It's the highest risk sport of all, Paul. I really want to get back. Believe me, if there's a way for me to do it, I would. What I foresee is going to happen, if you have antibodies to this, if you've been vaccinated and show some immunity, I think there still has to be some more studies to show this. I think what's going to happen is that the United States will probably jump the gun and lift restrictions on people, and we'll probably have what's called the COVID club, where people are actually who've had the antibodies will hang out and won't be able to transmit it and won't get sick from it. This is provided we know for sure that people who have those antibodies won't get infected again. I don't think you can. Even with these crazy kind of things coming up, I think it's probably because of a lack of testing, or the testing wasn't good enough. If you are a part of the people who actually have antibodies, and you'll have your little stamp like, oh, I passed, and believe me, there's going to be forgeries out there and people saying that they are, and yahoos are going to try to get infected with COVID thinking that they're going to be immune afterwards, which I tell you not to do because it can be deadly. What I see is happening in the foreseeable future is that if people are vaccinated and have had it before and show antibodies, then you're okay to go leave shelter in place and go do things like jujitsu. Now, if you are antibody positive, I foresee in the future you'll probably be able to roll, but that's what it's going to look like. Without having antibody testing, without having any trajectories or anything like that, I don't think it's going to happen, because this is the highest risk sport of all. You're contacting people. If somebody blows their nose on the mat, everybody gets it. You're going to roll in it. You're going to transfer it to your face. Somebody puts you in side controller mount, you're going to get it. It's going to be all over you. And you guys know this too, because it's at the end of the day, you can have like stuff going in. You can get staph, and you can get ringworm and other things. It's one of the highest transmissible infectious disease sports out there. And you can get like pink eye and other things too. So what I foresee happening is, and it's not going to happen this month, may not happen in June or July or August, if we get an idea of who's tested positive or get antibody testing, maybe you'll get a smattering of people who can go back if you have antibodies. In lieu of that, if you have an immunization, then you can probably do it later on. There are people like rolling in their own garages and stuff like that. I'm not quite sure. If you want to risk it, you can, but then again, you're going to risk transmitting it to other people, and I don't think it's actually a good idea. It sucks, because part of me wants to just say, fuck it, I just want to do it. And the doctor side of me saying, this is not realistic, it's not going to happen for months. But I think antibody testing, your COVID club card, or whatever it is, and then you can go roll at the academy. So that's going to be several months down the line.
So, but barring that, it's just nothing. It's no like I heard about some daycares and stuff where it's like if it's the same group of 12 kids every time, they're allowed to do that. And so I was thinking maybe that's something that we could do in jiu-jitsu, like if it's the same 12 bowling buddies every time. But you think no?
That's the thing.
So I read a Gracie gym in Austin, Gumby. I meant to text this to you, but I'm a terrible texter. I can't type. They're coming up with a plan where you are permanently assigned to a pod of 8 people. Okay. And you only train with that group of 8 permanently, and you have a 45 to hour long class, and you only train with those guys. And then they spend 15 minutes between classes completely disinfecting the mats, because I've actually read a lot of disinfecting can take up to 10 minutes.
Yeah.
But then you're kind of, and it was funny, we just had like a Zoom just happy hour with like Julius and Dar, you know, and even 8 kind of, like we were talking, 8 kind of seems like a lot, but the concept is interesting, right? Like you're in a permanent group and you only train with that group.
So the risks are way lower if you do that. I totally agree. But you have to make sure that all 8 people are also isolating themselves as well, and will tell you that, hey, I got a fever.
Right.
You get a fever, and that's the same thing. Some people can be without symptoms and still shed the virus and still have it. So,
but that's the difference between infecting 7 and their contacts versus, you know, 30 guys and their contacts.
So I can only tell you about the medical way of dealing with it. Like about socioeconomic sort of things and legal sort of standpoints is a totally different ball of wax. What I foresee is happening, something like that may happen. Is it medically safe? No, it isn't. Are we willing to compromise here? I think so. We kind of have to do this, otherwise we're going to go nuts. Seriously. I mean, now it's like, for me, not going to jiu-jitsu and going to my job actually impacts my job, because I'm in less of a good mood when I go there.
I feel you.
That's the thing.
Totally.
I wish it was there. So is it going to save people's lives? I guess you could say that, or I could just as well just lift weights, which isn't fun at all. So that's an interesting way to cut down on the amount of infections. Do I think it's sound? No, but I can understand people wanting to do it, because you have to come back to it at some point. You really do. And if you weigh lives versus, you know, your sanity and things like that, these are things that are philosophical questions that I can't really answer. So that's actually a pretty good model. And if you wanted to do something like you could. Honestly, if that happened, I'd probably jump on it, even though it's not completely medical sound, because.
So yeah, I like that pod idea. And then, you know, from the very beginning of this, I assume there'd be some sort of like card you would have, which now you've already alluded to, where
you would have,
you know, I've been certified, and of course there's going to be forgeries, just like fake IDs. But I feel like with limited small pods and certification of antibodies, and I'm in a semi-risk group. I have inflammation, I have rheumatoid arthritis.
You do.
I mean, yeah, it's very scary for me personally. I think maybe less so for other people, but I feel like that small pod concept, you know, maybe well thought through is maybe, and I acknowledge what you're saying. As a medical professional, you can't say, yeah, this is safe. As a legal person, you can't say, yeah, this is safe. But in terms of just, day to day, it's better than, oh, I'm going to roll with like 20 different guys in comm class. It's better to be in that small group.
Yeah, it would be best.
But even for a small group, if they leave shelter in place, then it will be exponential growth in context for everybody.
Definitely. And so that's to his point of saying, you know, as long as those 8 people in your pod have told you and are honest and candid, saying, you know, I've tested for antibodies.
Until everybody in that group is tested positive or negative.
Oh, yes, that's what I'm saying. Totally. Not just one person, everybody. I agree.
It doesn't matter if it's 8 or 80 or 800, it's still a risk, right?
Right, but the risk goes up more just in terms of being honest. Sorry, had to say it, but yeah, if you have a group of 20 people, the risk of one person fudging versus 6 people is bigger.
That's
more people.
A lot like sex. The more partners, the more problems.
Right. That's why that's why I was saying we were talking, you know, with a few people, like Dar was like, yeah, I like that idea, but only 6, you know. So obviously the smaller group is medically better to manage, but, you know, then from a jiu-jitsu gym point of view, that's harder to manage, right?
Right. So the odds go up exponentially after you. Like if you have a training partner, like, I mean, we have Bobby there. If you roll with him, you're locked to that person. If you have a training partner, if you could bring it to a third person or a fourth, it does go up exponentially. You're right.
You? But she's shoving you and you're shoving me.
Okay. So we can be real creative with this. I don't know, Gumby, have you thought about getting UV lights for your gym?
Getting what?
Hold on, let me get one for you. I'll show you. I'll be back.
To be clear, like I've seen and I've been in a lot of these discussions with like, I've talked to tons of school owners and stuff like that. Some good ideas, some really bad ideas out there. And I'm kind of on a wait and see and talking to a couple of folks that I would trust their expertise a little bit more on infectious diseases than I would trust most jiu-jitsu instructors. I always like to throw out that I'm not a doctor on this, but I'm relatively certain that the format of, at least when we come back, at least for the first area, of more classes, less interaction is going to have to be there. But exactly what level we have to do that is going to be there. I say more classes in the sense that, that everybody's not coming. I can't have 40 people in at one time to start off with. Is it 10? Is it 8? Is it 12? Do we all work on little dummies in there? I don't have a definitive answer on that. I'm kind of waiting a little bit more on the science on this. And again, some expert opinions that I trust a bit more than most of the instructors. And I'm also kind of waiting and seeing. It's like I'm glad we're not the guinea pigs on this right now. Like you're going to see not only like you'll see in California, there's already like schools that are defying shelter in place. And you'll probably see more of that too with the economic pain that everybody's feeling on that. And then you'll have folks that are legitimately able to do that. Houston, Texas schools, Georgia schools, a few other ones, right?
Yeah, just watch Gary Tonnen's school. Brunswick is probably going to open up at some point because he's hopping mad and ready to start again.
Some of these have been open already, or some of these never really went away, or like, you know, like, or people still think out there. Like I said, we're going to see, like I said. Like I said, you know, I think certain schools are able to open up as soon as last week, Friday. The Georgia ones, I think Texas ones are open up right now.
There's your hotbed you're going to get to see. It's the experiment to see what happens. So this is a UVC light. So this cost me like $60 on Amazon, and it's a pretty good light. So it's UVC. So there's 3 types of UV light there. There's A, B, and C. So UVA is usually the black lights that you get for Halloween. They don't do crap against COVID. UVB is better, and it tends to be the hospital type ones that are in front of the hospital, which can sterilize things. UVC actually will kill this in a few minutes. So it's about, I think the wavelengths are on the order of 280 to 290 nanometers. And if you put this like 4 or 5 of these above your gym and turn them on for an hour, you've disinfected the mats. You really will. The air around it and everything. If you put the changing rooms and put those things in there, this is a quick way for you to do it. The problem is that you can't stare at this lamp, because if you do, you'll get radiation keratitis and you'll burn your corneas within 10 seconds. So it's like the tanning lamps. If you go in for a tan, you have to have those goggles on. Nobody can stare at this thing. They may have better ideas to do it, like a Roomba-like robot, which goes across the mats and actually shines a light on it. It would take a few seconds if it's just in close proximity to it. But if you leave a light like this on between classes and nobody goes in there for an hour, you effectively like disinfected the mats and everything. And it's a pretty cheap way to do it. And I bet you hospitals are going to do this as well. So that's maybe one thing you want to look into. But they have to be like legit 290 or to 280 nanometer UVC lights.
You're going to have to send me a link to that. I can think at least in the downtown gym, how that wouldn't be too hard to put in the downtown gym, the east side gym.
Just hang like 2 or 3 of them and then just like irradiate for about an hour. So you can use mat side and all that stuff. That'll kill it too. Most of the stuff you use to clean the mats will also kill it pretty dead.
One other thing that I've heard rumors of that might kill it, you can tell me whether I'm completely off base, is ozone. Does that do anything?
Yep. Yeah, it does. Ozone, actually, it's unsafe for people, but
if nobody's going to be in there, like,
no, but you don't need the ozone producing lamps at all. You just have to have UVC. That's all. It just makes things a little bit more difficult for you to. You have to worry about the ozone afterwards and clearing it out. With just a UVC light, you don't have to worry. So that's one way to do it. So if you if you were to ideally do this, it would be a limited number of students, maybe a COVID card and COVID club, but you'd have to like sterilize your mats afterwards. And just really track people. Like if they come in, you're doing spot temperatures on everybody who comes in. If you want to be really anal about it, you'll do a pulse oximeter and all that, but I don't think that's really necessary. Most people just be real honest with yourself before you come in. If you're sick, don't come in, don't roll, don't do that because you'll get people infected. So I don't know, Gummy, I'll work with you and I'll try to figure out what else you can do to open the school early. I would love to because I'm literally dying without this sport. And I think most people are gonna say the same. And yeah, hopefully in a few months.
And we'll talk about that offline. There's at least a couple of articles I've seen that have been written up, but I have, for the record, I have yet to come up with a comprehensive plan because I want more information.
Yeah, you want to be safe about it too. I understand. So that's interesting about the 8 people rolling groups or pods. Any other questions, guys?
I got another one right there. So like, in addition to like, I mean, COVID-19 is obviously dominating everything else, but there's other, I'm sure there's other illnesses that we have to worry about too. Like, flu must still be going around. It's still flu season.
Flu's done.
Oh, okay.
They've actually stopped testing for it. So the flu pretty much follows the seasons, and there's very little flu out right now. So what we were used to doing is a combination therapy. When people got sick, we used to give them Tamiflu. Now we don't, especially if you're giving chloroquine or hydroxychloroquine, because you can go cardiac dysrhythmias and die from it. So we're not really treating for it, and we're not really screening for it. In fact, our lab stopped testing for it like yesterday because it's so low incidence. So we don't have to worry about the flu.
Well, I have a 2-part question now that I think about it. Like, I've seen what the COVID-19 test looks like, and it looks pretty unpleasant. Like, it's the swab up.
It sucks. It sucks. If you
antibody test.
The antibody test is just blood test, but the nasopharyngeal test for COVID sucks ass. They take a long, it's literally this big, and they stuff it in your nose and they leave it in there for 30 seconds.
Oh shit.
And then they turn it and leave it again and pull it out. They use the same swab because we're running out of swabs to swab your mouth. So it goes from your nose to your mouth to save on 2 swabs.
Yummy.
So it hurts. It's not fun to go through. I don't ever want to go through it, but perhaps I'll have to at some point. Yeah, it's not a fun test, but that's the only way you can actually get an adequate sample. In Japan, they actually have people gargle and spit it out. Actually, is a better test and less painful, but we don't do that here. Any other questions?
Exam and at the same time.
I just want to say thank you so much because I know you're a doctor, but I genuinely feel like you're so empathetic and you love jujitsu. And so I think all those qualities combined are just, it's like been very great to hear you talk for an hour. Thank you so much.
No, I miss you guys. I really do. It's been.
I'm gonna cry. I've already cried like twice during this talk. So I appreciate your candor because you've been very candid, and I think you're, again, I know you and I think you're empathetic, but you're being very honest, and I think that's important for a lot of us.
Thank you.
Yeah, thanks, Dr. Mike. It's been super informative, so appreciate it. My wife.
Yeah, thanks, Dr. Mike.
So.
Yeah. If you guys have any other questions, just shoot. I'll follow the posts that Agami showed, and I'll answer them, or you can direct message me. I don't care. It's fine.
Thank you, Dr. Mike.
Yeah, Gummy, do I have to give you control now, or can you take?
Well, you had a screen. Didn't you have a slideshow you were going to do?
Just to show you, like the shelter in place has been really effective, and the number of cases that we have in California. Like I said, right now for Santa Clara Valley, it's only 150 patients. We don't have that many patients in hospitals with it. The ventilators, we have plenty of them. The surge beds capacity, we have plenty of them. It looks pretty rosy from the hospital standpoint, so it's not that bad. In fact, there's less people in the hospital coming to the hospital now because people are scared, which is not what I want to see. So nationwide, and God bless us. I don't know what's going to happen in those other states. California has done a kick-ass job. Whatever we've instigated has been great. Shelter in place has actually worked. And so our numbers are way better than other people. That's all I wanted to show, really. And that the overall incidence of the disease is probably going to be less than we think. So hats off to everybody who's doing shelter in place. It's worked. It really has. That's the only slide I actually wanted to show. So anything else? What do I have to do on my end here, Gumby?
I can take it off the post on the self, actually.
Okay.
I don't think I was ever, you were ever a host on this, or you were at one point.
Okay. So
everything goes, there we go. Boom.
Okay. Okay, good. So I'll say goodbye because I got to make dinner because I got 2 kids here. Yeah, hopefully I'll see all you guys again. I'll drop in for another session, and hopefully we'll see you guys on the mats soon. Okay.
All right, we're about to go get bottle service. So, all right, guys.
Thank
Awesome.
you again, Dr. Mike.
All right,
Thank
guys.
you.
Thanks, Dr. Mike.
Dr. Mike. You're awesome.
Later, guys.
Take care.
Take care, guys.
I think some people are staying on. You hanging out?
I'll go ahead and stand.
That might be staring at that.
Gumby?
Go get your drinks, Bobby. We can drink without you.
Okay, there you go. Oh.
Doctor's done. Refill.
Hey, Karen, what are you drinking?
Got as fuck here.
Rita.
Hazy double
Sonoma tart.
Yup.
Nice. This is a Paloma. Tequila and